Uh, am I audible and visible? Then I'm gonna talk about extrapulmonary tuberculosis in this video. And if anyone is interested in joining in and taking this discussion forward, then I'll be very glad to do that. So, the thing that I want to talk about is, at first and foremost, is pericardial tuberculosis. So, the key point that we need to remember while we are discussing about pericardial tuberculosis is the diagnosis is done by ECG, chest X-ray, and transthoracic echocardiography. ECG may reveal evidence of pericardial effusion, low voltage stress, T-wave flattening, or inversion. Patients are at risk of atrial arrhythmia. Chest X-ray features of suggestive pericardial disease include hilar burdening and a globular or water bottle heart shadow. In some cases, the cardiac shadow may appear normal. Evidence of pulmonary TB or pleural effusion may be noted. The echocardiogram reveals or confirms pericardial effusion, annular constriction, and can detect signs of impending tamponade and requires urgent intervention. Cell count and differential count predominantly lymphocytic. Protein LDH with paired serum values. Exudative uncertainty in diagnostic utility. With discriminative evidence. Malignant cytology, at least 3 samples. Cultures in cheat culture positive in two-thirds of cases. Okay. ImJIT, which is a liquid culture, which is positive in two-thirds of the cases. And Gene Expert, discriminative evidence regarding utility. Is my voice audible? If anyone is watching, I would request that person to comment whether my audio is audible enough. Am I audible? MJIT culture positive in two-thirds of the cases. Gene Expert, discriminative evidence regarding utility. Discriminative evidence regarding utility. Pericardial fluid add a utility. According to a study done by Reuter at L, pericardial fluid at a more than 40 unit per liter had 87% sensitivity and 89% specificity. A meta-analysis by Tuan et al. In the same year showed a sensitivity of 88% and a specificity of 83%. NAT. A study by Pandy et al. Showed a NAT had a sensitivity and specificity of 63.8% and 100% respectively. A similar study at Sharma et al. In 2024 on NAT in different extrapulmonary tuberculosis samples showed a sensitivity of 25% and specificity of 94%. Pericardial biopsy. Diagnostic biopsy. In areas where tuberculosis is endemic, a diagnostic biopsy is not required prior to commencing empiric anti-tuberculosis treatment. In areas where tuberculosis is not endemic, a diagnostic biopsy is recommended in patients with more than 3 weeks of illness and without etiologic diagnosis having been reached by other tests. Empirical treatment for tuberculosis may be started in these patients in case of inconclusive investigations after ruling out evidence of malignancy in pericardial fluid cytology. Malignancy needs to be ruled out before we empirically start the treatment of tuberculosis in cases of suspicious pericardial effusion. Treatment 2-HRZE, 4-HRE for a total duration of at least 6 months. 2-HRZE and 4-HRE for a total duration of at least 6 months. Use of corticosteroid and initial adjuvant corticosteroid therapy may be used. Initial adjuvant corticosteroid therapy may be used. HIV-negative corticosteroid may reduce deaths from all causes and the need for repeat pericardiocentesis. Prednisone in a dose of 1 mg per kg for 4 weeks, followed by 0.5 mg per kg for 4 weeks, and tapers gradually over next 2 to 4 weeks. 1 mg per kg for 4 weeks, followed by 0.5 mg per kg for 4 weeks. Taper gradually over next 2 to 4 weeks. Taper gradually over next 2 to 4 weeks. Surgical intervention. Pericardiocentesis indicated as an urgent intervention in cardiac tapeworm. Pericardiocentesis indicated as an urgent in cardiac tapeworm. Pericardiotomy and out on treatment option in constrictive pericardial disease as a late complication. On treatment option in constrictive pericardial disease as a late complication. Predictors of improvement. Clinical. Normal tubular venous pressure. Resolution of pedal edema. Normal JVP. Resolution of pedal edema. Symptomatic improvement. Radiology. USG. IVC normal diameter and collapsibility. IVC normal diameter, collapsibility, decrease in dimensions of diffusion on the core. IVC normal diameter and collapsibility, decrease in dimensions of diffusion on the core. Causes of poor response to editing, alternate diagnosis, inappropriate dosing, coexisting other infection, non-compliance, non-compliance, alternate diagnosis, drug-resistant tuberculosis, coexisting other infection, poor drug absorption or penetration, immunocompromised status, paradoxical reaction, poor drug absorption or penetration, immunocompromised status, paradoxical reaction, drug interaction. Drug interaction. In cases of poor or non-response to treatment, reevaluate for alternate diagnosis and rule out drug-resistant TB. Cardiac temporal life-threatening disease. Pericarditis, tuberculosis, iatrogenic trauma neoplastic, intestinal chest pain, discomfort, dyspnea, kidney progressive nature, big strand, urinary JP, hypertension, muffled sound, tachycardia, functional signs, blood clot, JP, pulses, paralysis. Two-dimensional echocardiogram shows illustrating cardiac temporal with right atrium collapse or indentation. Need pericardiocentesis, preferably under echocardiographic guidance. Uncorrected bleeding diathesis, severe pulmonary hypertension, pulmonary hypertension, specific indication for surgery, aortic dissection with trauma, rural diffusion, volume depletion with fluid, volume depletion with fluid. Investigative investigation algorithm. Causes of pericardial effusion. Number of other causes of pericardial effusion. Autoimmune, haploidable, double uremia. मैं ना छूता तलक तुमको नहीं छूता